Cool. Are we all in?
Yeah.
All right. Can everyone try and use the chat function, see if it works? Oh, nice. Excellent. Right. Okay. So I better start then, haven't I? So we've only got 40 minutes for this. Most of it's going to be probably technical issues. So we'll just see how it goes, see how far we get in. Hopefully it's interesting. There'll be a lot of questions. So make sure you use the chat function to make it as interactive as possible. Okay, cool. So these lectures will also be saved and shared, hopefully afterwards, so you can revise from them or use them as you will. So let me just start the timer. Cool. Okay, so my name's Alex. I'm a fifth year integrator. Today we're going to talk about core surgical cases. It's probably going to be a lecture series because we're going to go through core surgical presentations, discuss the surgical specialties, and then talk about a few smaller managements as part of that. Cool. Yep. So the aim is to learn through doing. We're going to use the chat as much as possible. So please make sure you message answers or any questions that you have. We'll have 5 minutes questions at the end, but if you have any questions during it, please drop it in the chat and we'll try and explain it as we go along. Okay. So most of the sources for the lectures will come from the BMJ or NICE or local guidelines. So most of it is from local guidelines, and that's what your exam's going to be basically. To a certain point, it's about diagnosis and knowledge. And then past that point, it's about, do you know the guidelines really? Okay. A lot of this stuff you should know already, but there might be some new parts, and hopefully we can refresh your memory as well. Okay. So we'll start off with discussing the quadrants of the abdomen. So you see the 9 quadrants and also the general above, which are parts of things that can cause general abdominal pain. Within the compartments themselves, you have different things that can affect different parts. So today we're going to talk about the epigastric region. So you can see we have acute peptic ulcers, pancreatitis, biliary colic, MI. There's also, maybe have AAA in epigastric, and there's probably more as well that you have in epigastric. Cool. So let's start with the case, shall we? So make sure we're all in the chat. So a 40-year-old male who's arrived by ambulance. He's found in a pile of blood. Some is found around his mouth. Got to keep admitting people to the chat. Okay. Oh dear. So he's found in a pile of blood with some around his mouth. So how do we know that this patient, if there's blood around his mouth, how do we know if it's from his stomach or from his lungs? How can we tell the difference? Is there any way we can tell the difference? Color? Okay, yeah, nice. What would be the difference in color? Volume? Yeah. So which one's which? So if you're talking about volume, which one would produce more? Would the stomach produce more volume or would the lungs produce more volume? Yeah, nice. So stomach would produce more. You'd think in the stomach you get more volume with blood than you would in the lungs. Anything else you can distinguish between the two? Okay, so one of the things is obviously in the stomach you've filled with acid. A good way to distinguish between whether it's you're bleeding from the lungs or from the stomach will be if, sorry, I have to do less technical stuff on here every time somebody tries to join the chat. because of the acid, you get clotting, so you produce much more clots from the stomach than you would from the lungs in an acute bleed. Cool. So what we're going to start with, what do we assess every patient with that comes in with acute management? Nice, A to E, lovely. Okay. So we'll do A to E. So we'll go through each part. If anything sticks out to you, thinks interesting, drop it in the chat and we can discuss it as we go through. Okay. So the patient's general appearance is quite disheveled and unkempt. Okay. Patient's airway is patent. That's good. Patient's breathing is regular with equal expansion. Trachea central and respirate is 22. Anything so far? High respirate, yeah, nice. So slightly raised above the 20 we'd normally use as a threshold. Right. Patient's BP is 90 of 62, heart rate of 112, cold peripheries and a cap refill greater than 2 seconds. I'm hoping we're going to get one now. Nice, low BP. Hypotensive tachycardia, yep, we've made an inference there. Cool. So the disability, GCS 14 out of 15, pupils equally reactive, temperature 37, glucose 6.2. What do we think the importance of GCS is in a patient that has been bleeding, like haematemesis? How might it affect our management in the acute phase? A low GCS. Nice, intubation, good, good. So in a patient with haematemesis and you have a low GCS and the patient is unable to gag or to hold their airway, you would intubate the patient immediately. Excellent. So this patient is 14 out of 15, but he just scores 1 for confusion in the state because it's hypotension. Right. So the patient, we expose the patient, there's no bruising. The abdomen is soft and non-tender, which is nice. And what else do we need to check in this patient who's had haematemesis? With part of the exposure procedure. Nice, PR, excellent. Straight in there. So because it's bleeding from the stomach, we would have to do PR to check if there's any rectal bleeding or any melena. The DRA is negative. Okay. So we think this patient's probably in hemorrhagic shock due to this low BP, hypotension, got the high heart rate. So what stage do we think the patient might be in hemorrhagic shock? If you want me to go back to the previous slide, just drop it in the chat. Three, two, 3. What makes you think 2? What makes you think 3? Yeah, confusion. And that makes you think 3? Yeah, so I would lean towards 3 more because of his blood pressure. It's decreased, and in the other 2 classes it's normal. And you've also got this anxious state the patient has, so probably going to be more 3. So you're looking at 1,500, 2,000 milliliters of blood, which is quite a lot actually. So how are we going to treat a patient who's had massive hemorrhage? So for the guidelines for massive hemorrhage, it should be a loss of about 50% total blood volume in 3 hours, which is quite a lot of blood in 3 hours. But normally you base it on like BP and heart rate. So you're looking at a BP of 90 or less is a major hemorrhage, and a heart rate of about 110 or over. So you won't need both those two things for major hemorrhage. And in the treatment of major hemorrhage, we're going to start with 2 liters of warm saline under gravity and then reassess vitals after this. If the hemoglobin is below 70, you want to start with 1 unit of blood and then give a second if necessary. And you want to aim between 70 and 90 for hemoglobin. You don't want to give too much blood, so you want to keep it around that 70 to 90. And if the patient under gravity, okay, so under gravity just means not without any of the pressure. So, you can have the pressure bags that push saline through faster. It just means just put it on under gravity, let it just drip normally. Cool. So, okay, so for platelet transfusion, so if a patient is actively bleeding and has a platelet count of less than 50 to the 10 to the 9 per liter, you want to give a platelet transfusion as well. But if a patient is also thrombocytopenic, this is a higher threshold of 100 because they're more likely to bleed. Cool. All right, nice. So this is a little game, okay? Let's see how interactive we can get. So this is blood transfusion types. There's going to be a few pictures that come up, and you've got to guess what type of transfusion type it would be. So, the different bags you have, like cryoprecipitate, red blood cells, FFPs, that kind of thing. All right, so here's the first one. Pretty simple first one. Nice, red blood cell, simple. Let's go to the next one, shall we? This one is a little bit harder. Platelets, nice, cool. This one's even a little bit harder. Nice, cryoprecipitate. Okay. Does anybody know why the clotted cream is on top? How is that helpful? Yeah, how's factor 8? Yeah. Okay. So before the use of isolated factors, you would give cryoprecipitate if people had hemophilias. And in desperate times, you would give cryoprecipitate if you don't have the isolated factors themselves. Nice. Here's the next one. This one's a little bit harder. You might get this one by what he's holding in his hand. It's the brand name for a drug, which is reversed by this. Yeah, Coumadin is warfarin. Nice. So what transfusion type might you use to reverse the effects of warfarin in if you had a major hemorrhage following BNF, major hemorrhage treatment, with a patient who's on warfarin, what do you give? Okay. So this one's prothrombin. So you've got the warfarin there. So if you have a patient who's got one on warfarin, INR above 8, has a major hemorrhage, you treat them with prothrombin to reverse that because of the factors which owner has discussed. Last one. Yeah, fresh frozen plasma. Nice. Cool. So what do we actually do then? So now we've given the patient some fluid resuscitation due to the protocols of major hemorrhage. We should also start giving them oxygen, 15 liters, to oxygenate, fully oxygenate the red blood cells they do have left. And then we have bloods. So ABGs, FPCs, clotting, urea, electrolytes, all the classics. Why are we going to take an erect chest x-ray of this patient? Yeah, nice, pneumoperitoneum. So if you're looking at a perforated ulcer, you want to see it. You might see air below the diaphragm, so you want an chest or X-ray. What other pathologies might you see on a chest X-ray which could lead to haematemesis? Might be a bit tricky, this one. So I'm going for Boerhaave syndrome because the patient would have the tear, the haematemesis, and they would also have like a pleural effusion due to the blood surrounding the lungs. And then we finally finish with monitoring. So the patient needs catheterization to monitor their urine output because that affects, you can monitor how hypovolemic. What do you see on X-ray with Boerhaave? You would see a pleural effusion on the left side. Because of the blood that seeps into the lung. Cool. And then a CVP if necessary. So a CVP will be required to monitor the patient's hypertension. Cool. So here are some bloods. Make sure you text in the chat what you think might be going on in the situation or what's wrong. Yeah, low HB. Nice. Straight in there. Low platelets. Yep. Sorry, there's no reference ranges. I was going to put them in, but it took up too much of the screen. But I think you should know that it's below 100. So the normal MCV should be between 80 and 100. So the MCV is fine. So you're looking more at normocytic anemia just due to hemorrhage. Okay, cool. This might also annoy you as well because there's no there's no reference ranges. Yep, acidotic. Yep. If you want to, get up on your laptop reference ranges. Yeah, metabolic acidosis. Nice. Is there any compensation in this patient? Do you think? Oh, we've got a fight. Nope, a nope and a yes. Why do we think no? Why do we think yes? Oh, Katrin, you've gone back on yourself. Okay. So I would say in this patient there was no respiratory compensation because the PO2 is within range. The PaCO2 is within range as well. You'd think if there's compensation, you would have the. Oh, I would like to explain base excess, but I think that I would be here for a long time. We haven't actually got very long on this, but hopefully in the future we'll have more lectures on metabolic diseases, things like that. If that's okay. Sorry. Okay. Yeah, it's being recorded. So if you want to rewatch it again, you can do. And I'll send the slides and things like that. Yeah, slightly high sodium. Yeah. Basically, what we're getting here is just it's a mild dehydration, really. Nothing really too much that's going on. And the urea is high, yeah. The clotting of the patient is normal. And LFTs are normal. Mostly because I don't want to go through them because it takes too long. Okay. So this patient can't really provide a history. They're a bit confused. So you can't get much out of them. But if you had a patient who was presented with epigastric pain, what kind of questions would you ask to aid your diagnosis? Oh, go straight in with the binge drinking, okay. Does it consume after eating? Yep. Go for a Socrates. Nice. Always good to do that. Any recent scopes? Nice. Worst lying down. Plasmal history. Meds that cause PUD. Sweating, radiation down the arm. Nice. Very important. Radiation to the back. Get a cholesterol history would be very helpful, wouldn't it, in this patient? Okay, yeah. Steroid use. Great. So there's loads of questions you can ask about epigastric pain. I think one of the best resources to make sure you're hitting all the points is things like OSCE stop. They always have a thorough history taking section. So you want to differentiate really between an ulcer, something like acid reflux, cardiac arrest. If the patient is maybe 50 plus, you want to exclude cardiac arrest really. In epigastric pain, you want to do an ECG, you want to do troponin, those kind of things, just in case. Acute chronic pancreatitis, gastric carcinoma are very important. We'll talk about that at a future point. Okay, right. So now we need to risk assess this patient. So we've had a patient who's had a hemorrhage, had a hemorrhage and is bleeding out from the mouth. So how do we assess patients who've had haematemesis? Okay, great. Sorry, kicked me out. Right, let's continue. So, risk assessing patients with haematemesis, right? So, do anyone know what the Rockall or Glasgow-Blatchford scores are? And which one we use pre-endoscopy and post-endoscopy? So somebody said Rockall post-endoscopy and Glasgow pre. Nice. Yeah, so we use the Glasgow-Blatchford score before endoscopy and we use Rockall afterwards. So the Glasgow-Blatchford score we would use, we would use to assess a patient's risk of needing to go to endoscopy. So if a patient's got zero risk on the GBS score, then they can basically go home pretty much the same day. If the patient has, I think it's above 8, then the patient needs to go as a 50% chance of mortality. So needs to go straight for treatment, not even endoscopy. And then we use the Rockall score for post-endoscopy, and it's usually used to determine what we think was the cause of the haematemesis. Nice. So a little bit of anatomy. So what is an upper gastrointestinal bleed? So it's a bleed where the origin is above the ligament of Treats at the duodenal junction. So here's a little diagram. An upper GI bleed can be separated into 2 categories, variceal and non-variceal. We'll start first with a little picture. What's happening here? We're in the endoscopy. What's happening here? It's not an esophageal web, no. No. Can you see it very well? I don't know. Yeah, you got a hemorrhage. What's going through? Can you see my thing? What's this going through the middle? Yeah, it's blood spurting. Yeah. So you've got an ulcer on the side here, or this side here. Sorry. Oh, which is spurting out all this blood down here. Okay. And how do we classify? Does anyone know what classification we use to say how bad the bleeding is, or how the classification is used to the risk of rebleeding post endoscopy? Does anyone know what we use? I think I went to the slide a second ago. Forrest classification, yeah, nice. Everyone is smashing this. So we use the Forrest classification to predict the rebleeding rates for patients. Oh yeah. Oh, you messaged first, so it's all right. So it's important when you're arranging second endoscopy because you want a second endoscopy afterwards if you had a bleed to check that your initial hemorrhage is finished. So you got the rebleeding rates down the side. And what classification would you use for this one? Probably. It looks like it's spurting quite a lot to me. So I would say 1A2. So it's very likely to rebleed. So you'll probably want another endoscopy within the next day to check that it's healed over. All right, here we go. So it's your worst nightmare. During the endoscopy, despite the patient bleeding out, the surgeon has taken the time to single you out and ask you a question. Oh no. So what's the question is, let me get the question on my phone. The question is, what's the most common artery perforated in a duodenal ulcer? Yeah, it's a classic. Straight in there with the gastroduodenal artery. I like it. So let's do a little bit of anatomy, shall we, to begin with. So you see behind here, posterior to the first part of the duodenum is the gastroduodenal artery. While we're here, let's do a little bit of quick anatomy about the celiac axis. So the celiac axis splits into the common hepatic, the right gastric, you have here, and the splenic artery. And this will be important later on when we talk about things like terlipressin. So how do we treat these then? We've seen on the endoscopy that there's bleeding. We can't just keep looking at it. We have to do something about it, really. So if it's a non-variceal bleeding, so we're thinking about things like peptic ulcers, you want to perform a dual therapy. So a mechanical method, like clips, as you can see here on the image, the patient is being clipped with or without adrenaline. And then you can thermocoagulate with adrenaline, or you can provide fibrin or thrombin to form a clot alongside adrenaline. Okay, so it's dual therapy. But what if you don't see anything in endoscopy? What kind of modalities can you use? So normally what you do if you didn't see anything in endoscopy is you would do a second endoscopy the next day to see if anything was visualized. After that, you can use things like angiography, so you can visualize the arteries themselves with angiography. And if the patient still has a low BP and low hemoglobin and you think they're bleeding somewhere, you have to go in eventually and do a laparotomy if you can't visualize it. Okay. So here's a angiography of the celiac axis. What are these? Oh dear. What are these things? Can you see running next to the spine? Surgical clips, nice. Oh, staples, yeah, either or, perfect. That would be a classic question in endoscopy. So post endoscopic treatment. So this patient has had a perforated ulcer, bled out through the mouth. They've had a low BP, but it's okay. We've given them blood. We've given them endoscopy. And now they've come out from the endoscopy. And what do we do after that then? So does anyone know where this is? Oh, nice. Everyone's smashing this, I thought. So this is Hong Kong. So we're going for the Hong Kong protocol here, really. All right. So I'm not going to put the numbers up yet because people are doing really well on these questions. So does anybody know what the Hong Kong protocol is? What? Oh, 80 milligrams IV omeprazole followed by oral. Okay. So it was 80 milligrams. Now the Hong Kong protocol is, it's 40 milligrams immediate infusion of omeprazole followed by 8 milligrams for 72 hours. And what this is for is to reduce the risk of rebleeding. So it's been proven that if you follow this Hong Kong protocol, that the risk of rebleeding is decreased. Yeah, infusion IV, yes. Yeah. So you give an immediate infusion of 40 milligrams stat, and then you give 8 milligrams per hour over 72 hours with this slow, continuous infusion. Does that make sense? Okay, cool. Thanks. So it's shown to reduce rebleeding rates. Right. Okay, here's another one. I think I had a bit of a spiel to begin with this one, but I haven't got enough time to do that. So what we're going to talk about now is antacids, mechanism of antacids, and how this works at a cellular level. So let's start with a classic PPI. So the PPI works by blocking this ATPase on the surface of the parietal cell. Let's see if this works. Cool. That decreases your gastric lumen H+, but also decreases the potassium in the parietal cell. But what we care about is the acidity at the gastric lumen. So the ATPase is being blocked by the PPI, and that's how omeprazole works. Next, we go into things like cimetidine or ranitidine. So histamine H2 antagonists. It blocks the receptor on the blood side, which decreases the H+ through the mechanism through the parietal cell, producing H+ cells, H+ ions, sorry. Okay, now we're going to talk about so steroids and NSAIDs. So steroids and NSAIDs, they actually do the opposite for what we want. So this is why we get a buildup of acid in the stomach. So they block these prostaglandin receptors on the blood side, which increases potassium, increases hydrogen ions being put into the lumen, and they decrease the mucus and bicarbonate produced by epithelial cells. Whereas the opposite effect is done by misoprostol, which is why it's also can be used as an antacid. What other situations are misoprostol used? What's it used for mostly? Yeah, so it's used in it can be used in labor, or it can be used in abortion as the second medication you give. Okay. So let's quickly talk about peptic ulcer disease itself. So I think we all know about the history, epigastric tenderness, pain related to eating. It can be nocturnal, can cause nausea, early satiety, or weight loss anorexia. The main risk factor itself is H. pylori infection. That's the most common cause of peptic ulcer disease. And also risk factors like NSAID use, increased age. So the most important investigation we have to do is H. pylori breath test. But it's only if patients age less than 55. Why is that? Do we know why we would only, as a first test, use H. pylori breath test for patients under 55? Why not for patients over 55? Nice, yeah, okay. You get the 2-week wait referral. A patient with epigastric pain and with dyspepsia over 55, 2-week referral for cancer, so they go straight for endoscopy. Great. And you're most likely to see a microcytic anemia in the FBC if a patient has had bleeding from a peptic ulcer, because they're going to have a little bit lower iron due to blood loss. Okay. So how do we treat patients with non-bleeding H. pylori negative ulcers? Non-bleeding H. pylori negative. Doesn't make sense, does it? Okay, yeah, it does. That's fine. So for patients who've had an ulcer, we treat them from 4 to 8 weeks with omeprazole, 20 to 40 milligrams, mostly 20 milligrams. We can always up it to 30 and then 40 if required, or another PPI. We also need to make sure we're removing other causes as well. So they can't be taking omeprazole and then necking back NSAIDs and smoking every day. So we have to be change some lifestyle factors as well. And the second line, ranitidine, 150 milligrams bi-daily, or misoprostol, 100 to 200 micrograms 4 times a day. But you're most likely only going to get to H2. Are people still taking ranitidine? I think people are still taking ranitidine, yeah. It's in the best practice guidelines, so I hope they're still taking it. And then what do we do if patients have Isn't there a shortage? Oh, I don't know about shortage of drugs. I'm currently not in hospital, so. Would omeprazole continue or stop? No. Okay. It's all right. The chat's helping me out. Big shout out to the chat. Okay, let's move on to the final couple of bits. So if a patient is not bleeding and they're H.pylori positive, how do we treat a patient with H.pylori? So we use triple therapy. So we need to give them omeprazole 20 to 40 milligrams per daily, clindamycin 5 milligrams per daily, and then amoxicillin 1 gram per daily, or metronidazole. And this should take place for 14 days. There's also other types of therapy like quadruple therapy, and there's resistant types as well. Is there a reason why we might not use clarithromycin in certain areas of the UK? Especially in Merseyside? Yeah, trust policy, yeah, resistance. So what kind of, what's causing resistance in Merseyside? And this would affect trust policy and trust guidelines. It's mostly due to, overprescribing, and then it's due to a lot of STIs becoming superbugs and therefore not being affected by clindamycin. What kind of side effects do you think you might get from this triple therapy? There's quite a lot of drugs there. Yeah, a bit of GI disturbance, yeah. A rash. You might get C. diff, yeah, amoxicillin and clindamycin. Nausea and vomiting, yeah. Thrush potentially. Read here. Okay. So mostly it would be things like diarrhea, like opportunistic infections, things like Clostridium. And then you also might get an effect on if people are taking prolonged QT. If you're taking clindamycin, you might also get an effect on patients with who are taking like birth control, things like that. So after a month, you want to do another test to check the patients have not got H. pylori anymore. And if they do, you repeat the cycle again. Okay. You would probably use the breath test again or stool antigen test to test for post-eradication therapy. Oh, so here's triple therapy. There's H. pylori. So I'm only allowed 40 minutes, so I can't go any further, but I have quite a lot more slides of this plus other cases. Hopefully we can continue this another day, maybe next week or another day this week if you all enjoyed it. I'm sorry, I'm still getting to grips with how to use all the functions and stuff. Yeah, I have to go though, because I'm only allowed to do 40 minutes for the sake of the teaching session. Yeah, the message